On behalf of the Lamb Foundation, it is my pleasure to welcome you to our Lambposium in Your Living Room Circle of Hope webinar. And I am so happy to see all the beautiful faces out there. And yes, Kathy Hahn, we're doing a special shout out to you. So lovely to see you and see you healing and recovering from transplant. We all have done victory dances for you. So thank you for being here. Tonight's webinar is being recorded and will be available on our website next Wednesday. My name is Cindy Beasley. I am the Director of Patient Services for the Lamb Foundation, and I will be your moderator this evening. Tonight, we are so fortunate, I'm so excited to have Dr. Sean Agbor present on recognizing and monitoring early signs of lung transplant rejection. Dr. Sean is a physician scientist whose work focuses on improving outcomes in lung transplantation. Originally from Cameroon, he earned his medical degree at the University of Yaoundé before continuing his training in the United States, where he completed a PhD in molecular biology at Georgetown and his clinical training at Johns Hopkins. He went on to specialize in pulmonary and critical care medicine and now serves as a Lasker Senior Investigator at the NHLBI Pulmonary Branch and as a lung transplant pulmonary physician at the Johns Hopkins Hospital. His laboratory of applied precision omics is based at NHLBI and aims to develop novel approaches to detect and treat transplant rejection. We are so fortunate to have him here tonight. Dr. Moss had recommended that he come. And so, Dr. Sean, we're delighted, and I'm going to turn the program over to you.
I would share my slides in a minute, but before I do that, I have to say I've given quite a few talks, as you can imagine, being at the NIH. This is only the very first time where I'm talking to a patient-focused group. So I'm looking forward to this, not only to talk about some of the work that me and my colleagues, my lab at the NIH are doing, but in hopes that I could also learn from how best to interact with you. So I'm hoping that there's quite a bit of interaction that I could understand a little bit of some of the concerns that you have about transplantation or related diseases, such that we can take back that information to the lab to help improve what we're doing. And thank you so much for inviting me. It's really an honor and delighted to be here. So I have a joint appointment at Johns Hopkins and at the NIH. My primary appointment is at NHLBI Heart Lung Blood Institute, where my lab is there, and I also see patients at Johns Hopkins. I have no disclosure, no financial disclosure, no links to companies or any thing that is worth. I have no disclosure. I work for the federal government. So I always start with these conclusion slides. My hope is that by the end of this, I will show you some data and some studies that we've published to convince you that you could use cell-free DNA as a blood test to monitor for transplant health. And that a positive cell-free DNA test does not mean rejection. However, it tells you that something is wrong. As it is now, it doesn't tell you what it is. It's just that rejection is the most common thing you find. And that the test could be detected, it could detect rejection earlier than biopsy. Hopefully, if I have enough time, I'll talk to you a little bit about some new modalities that are in the horizon. And then I'll invite my colleague, Commander Andrew Keel, to talk a little bit about a new initiative, a rejection clinic that we're setting up at the NIH. I know I said I don't have any disclosures, but I don't think that's exactly correct. Because the one thing I'll tell you is that I'm a little bit biased. Transplantation, in my mind, it's just a wonderful branch of medicine. If you think about it, a patient will unfortunately die. We've tried all types of treatments, and the treatments will not work. You take out the lung or you take out their heart. You give them a new organ, and that patient can live again. It I don't know, it just blows my mind that one is able to do that and give this second chance of life to our patients. If you don't mind, I'll start with a patient story. My lab people have seen this, but hopefully, this is a good venue to show this. I won't even say anything, but just to show the glories and the virtues of transplantation.
But there's no label for losing a child.
Christopher Brazel was just 8 years old in a crosswalk when he was struck by a car. At the hospital, Christopher's parents had a terrible decision to make, whether to donate his organs. Just a few doors down, 4-year-old John Hochstein lay dying.
And I got to thinking that if my son didn't make it, maybe that little boy would.
And for them to say yes, um, how do you put that into words?
For more than 20 years, both families had searched for each other.
This is a surreal thing to actually be happening, so it's very exciting. His heart's still beating inside my chest.
It's just so amazing. We try to live our life always appreciating the gift that they gave us, giving a gift of life is the greatest thing that anyone can do for someone else.
I have to say,
Dr. Sean,
yes.
I'm sorry. Do you have a video that we're supposed to be seeing or
Oh, the
slides
video
right
did
now?
not, it did not
No,
go through?
No, we can't see anything.
Okay, what's on your screen?
I don't have any presentation on my screen at all.
I saw it.
You did?
Yeah, we
I
saw
saw
it.
it.
Then it's just
Yeah,
me.
me
Never
too.
mind. So
Yeah.
sorry. So
Yeah,
Yeah,
sorry.
I saw
It's
it.
me. Okay,
Yeah.
good. My
So-
apologies. Yeah.
No worries. I've looked at this particular video more than 100 times, and each time I see it, it makes me pause. If you think about it, 20 years after this gracious woman, her son died, she could listen to her son's heart beat inside and giving life to Christopher. Christopher went to Harvard Med School, Stanford for fellowship. He's a pediatric thoracic surgeon now, interested to do heart transplant. That is what transplantation can do. That's where my bias is, as you could see. However, we understand that that story may not always be that glorious because you're putting the lung inside a hostile host, and that lung can get rejected either via antibody mediated rejection, or cellular rejection, acute cellular rejection. And in the lung, sometimes you get viruses, you get pneumonias, you get viral infections, and such that generally the outcomes after lung transplantation are generally very poor compared to other organs. So we do lung transplant to try to do that. My lab focuses as a mission to try to improve this. The very first thing we did was this. Traditionally, we are all worried about rejection, and so doctors want to catch it up early. The key to rejection is catch it early and treat it effectively. If you can do those two things, then your patients are generally going to be fine. This is the traditional way pulmonary physicians, transplant physicians, diagnose rejection. Several patients may be several of our colleagues here may be familiar with this. They take this long cable, which has a camera in front. We call it a bronchoscope. They bring the patient to the hospital. They put you to sleep. They pass this bronchoscope, this cable, through your nose or through your mouth, go down into your lungs. They take bits and pieces of that lung and they send it for diagnosis of rejection. As you can imagine, patients really don't like this very much. Putting them to sleep, putting something through their nose, the cable, yes, they're asleep, but it's not something that a lot of people like. Then heart transplant patients even get a whole lot more. Here, above here, you could see this is the schedule at the time at Johns Hopkins, where my clinical practice was, the number of times that patients would have this bronchoscopy. Heart transplants patients can get up to 15 to 30 of those. When you get the tissue sample, you send it to the lab for histopathology. That too has its problems, such that this approach, the standard approach or the gold standard approach, which is based on biopsy, could often miss rejection. Or it could pick it up at really late stages. And often, treating that rejection at those late stages, the patients do not seem to respond. There is a problem. Clearly, this is not acceptable. We asked the question earlier on, could we use a different method? Could we use a blood test, cell-free DNA, as an early marker to diagnose for rejection? What is cell-free DNA? These are short fragments of DNA that are released into the bloodstream when cells are dying, or if you think about the transplanted organ, when the transplanted organ is being rejected, the cells are dying and they're releasing their DNA into the circulation. That DNA, we call it cell-free DNA, and it's very abundant. So if you can imagine a lung transplant patient, therefore, this lung comes from a different person. That person has a different DNA from the host. Then as soon as you know that, everything else becomes really easy. It means that if this lung is being rejected, the DNA from this lung will be released into blood. And if I take a vial of plasma from that patient, I should have, therefore, DNA from that transplanted lung, which I will call donor DNA, and DNA from the host, here in red, which I'll call the recipient or the host DNA. And if I know that, everything is easy. I can pick my method. I can sequence that DNA. I can do PCR on that DNA, but I could do all that. It becomes really easy to quantitate the percent of donor-derived cell-free DNA as a marker of rejection. We set up a consortium from NHLBI to recruit patients to test this. This consortium is what we call the Genomic Research Alliance for Transplantation. And our mission at the time, which we call Graft 1.0, our mission at that time was to develop a blood test to detect rejection. So NHLBI sponsored with several hospitals in the area. We expanded that to include other hospitals as well. And now we've developed a transatlantic cohort of lung transplant patients with multiple samples. And bottom line, we've tested this, but let me show you some data on that. This is a patient from Stanford who developed acute cellular rejection. On the y-axis here is your donor DNA. If you look, the donor DNA is low. The patient got rejection, acute cellular rejection, or ACR. The cell-free DNA goes up. The patient got treated, this time treated effectively. You could see the cell-free DNA goes back down. That's a very important concept. Secondly, though, if you see the two lines here in red, these are samples, the same samples that were run in my lab at the NIH. And in blue are samples, replicate samples that were run at Stanford. As you could see, the test is very reproducible. So if two different labs do it, following the same procedure, the results are near identical. So we showed that the test can pick up rejection, but here's where I think the true benefit of the test is. If you imagine that time zero is when the biopsy says the patient does have rejection. If you look at that time, your cell-free DNA at the time when your biopsy or the patient shows any symptoms, your levels are high. But more importantly, 2 to 4 months before that patient develop antibody-mediated rejection variant, think about it. 2 to 4 months before that time, you start seeing a rise in the cell-free DNA. Early detection. If you look at it in heart transplant, the same thing as well. You start seeing a rise in your cell-free DNA, And all these time points that you see, we did biopsies. Biopsy negative, biopsy negative, biopsy negative, biopsy negative. Then biopsy ultimately becomes positive. All through that time, you have a rise in your cell-free DNA. As you can imagine, in lung transplant, this was really, patients loved the idea. And our physician colleagues felt like it was a good idea to use a blood test instead of biopsy. Now, the tests have a wrinkle. It is that the test is sensitive, very sensitive, and the levels would go up anytime there's something wrong with that transplanted lung. So if a patient develops a pneumonia, for example, you want to guess what? Your cell-free DNA would go up. If a patient develops an infection, the cell-free DNA will goes up. And so the cell-free DNA test, you cannot use it at current to distinguish between rejection and infection. So the test can tell you something is wrong with your lung, but it will not tell you exactly what is going on. So such a test could be actually the most ideal test to monitor patients for rejection. How do we use it? And this is what we currently do now at Johns Hopkins. And indeed, about 70% of US lung transplant centers currently use the test, or they are setting up protocols to do it. We monitor patients, we get patients to get their cell-free DNA levels. If the levels are low, it has a very high negative predictive value. If the levels are low, means there's a 97 to 99% chance that there's absolutely nothing, especially if the PFTs are good, everything is good. It gives the physician and the patients an all clear. Go home. And these are all based on studies. The graft is usually quite quiet. However, if the levels rise and they are high, we call that the alarm signal. Your levels are greater than 1%. Does it mean rejection? Remember, no. It could be infection, it could be rejection. So we ask that the primary team do a series of workup, get full PFTs, CT scan, do a bronchoscopy, get a biopsy, send cultures, try to figure out what's going on. If you identify a cause, if you don't identify a cause, resume monitoring, because as you know, cell-free DNA levels can start going up earlier before you see signs of rejection. If you identify a cause, then you treat, and we can use cell-free DNA to also monitor to see whether that treatment is effective. So this is what we currently do at the NIH. We don't do bronchoscopies anymore. At Johns Hopkins, we've reduced the number of bronchoscopy we do. At the University of Miami, we have colleagues who do the first bronchoscopy, but after that, all they will do is cell-free DNA, and they use this algorithm to move forward. And as I showed you earlier, this is an example of a patient where we use that, and I'll show a few patient examples as well. Now, as the test that is given, commercial partners of ours would provide this test to your various hospitals. They will report this value, percent donor-derived cell-free DNA. And as I showed you, this is all the data that I showed you. It works. It works the vast majority of time. But as you know, in medicine, nothing is 100%. There's sometimes that percent cell-free DNA does not work alone. You need other values. This is how you calculate the percent. It is the amount of donor divided by the donor plus recipient. So you can imagine if the donor stays constant, but the recipient changes, this percent is going to change, and it can give you a false information of what is going on with the patient. This is a patient, one of our patients that we monitor at the NIH. If you look here, this is percent cell-free DNA. And if you see, we monitor this patient over time. This is days post-transplant. The percent cell-free DNA is just very low, all within normal range, less than 1%, as you could see here. If we would look, the patient's PFT2 was fine. And so if we only use that value, we would be very consoled and say, oh, everything is good. But we also have another value, which is just looking at how much of the donor is there. right? And if you look at that, you look at how much of the donor is here in blue. This is normal range here. What do you notice? Between around day 370, you start seeing that rise in the donor cell-free DNA over time. While the percent is fine, the amount of donor keeps going up. Andrew Kiel, whom hopefully he has joined and will talk in a little bit, looked at this and said, man, Sean, I think we should do something about it. We had the patient, the first time we did a biopsy and we saw acute cellular rejection grade 1 for this patient. We treated it, the levels calmed down, right? So we saw something at that time. The second time, this is the second time I'm showing you that the patient's cell-free DNA just keep going up. We did a biopsy. The biopsy was negative at this time. But all we did then is we increased the steroid. The patient was on prednisone 5 milligrams. Andrew just took the steroid from 5 milligrams to 10 milligrams. That's it. Look at the cell-free DNA levels. It come right down. And then we modulate his immunosuppression to stabilize it. And so this is what we do now at the NIH. We monitor these patients. We use the cell-free DNA to inform us about what to do. So are there other relevant values that this test could give? Again, this is work that is really developed by our senior staff scientist in the lab, Moon. I have his picture there. He has developed these cell-free DNA methods that give us some additional value. This report would give you the host cell-free DNA. It will give you the percent cell-free DNA. This is what most of you would get in your clinics if you see this. And then it will give you the donor DNA in copies per ml, which is the amount. So it gives you 3 values. Your clinic now would give you 1 value here. But hopefully, we're talking to the manufacturers of the tests. Hopefully, very soon, they would also start giving you all 3 values. So something to watch for, something that is coming would be you getting all these 3 values when your doctors order the test. Now, what happens when a patient gets 2 organs? Let's say a patient has a lung and a kidney transplant. Now, you don't only have 1 organ, you have 2 organs. Can you use your cell-free DNA to tell you there's rejection? And if so, which organ is being rejected? Well, it depends. If the 2 organs, the kidney and the lung, are from the same donor, it can tell you, yes, something is wrong, but it cannot tell you where it is coming from. Is it the kidney or is it the lung? It cannot tell you that. However, if the kidney and the lung donor are different, then their DNA is different. It can tell you, yes, there's rejection, and it can tell you it is the kidney or it would be the lung. So it can give you that type of information. Again, this is data that Moon generated for one of our patients who got dual transplants. So I have here the number of days post-transplants, their total cell-free DNA, the amount of cell-free DNA from organ 1, the amount of cell-free DNA from organ 2, and this is the host cell-free DNA, as you can see here. If you look at this patient, organ 1, you have cell-free DNA less than 1%. There are only 40 copies of this. Usually numbers less than 100 is good. So this is pretty good. But look at organ 2. Values 374%, 6.38, greater than 1%. There's likely rejection going on in organ 2, but organ 1 is fine. Again, this is a case where the 2 organs are from different patients. You can still use the test. So here, we're able to find that there's rejection in organ 1, in organ 2, but not in organ 1. So you can do that as well. So I would come back here. I've talked a little bit about these take-home points. Cell-free DNA is a blood test to monitor allograft health. A positive test is not specific for rejection. You could see it in infection, so your doctor needs to investigate. The cell-free DNA can pick up rejection earlier, sometimes significantly earlier, and hopefully we'll talk a little bit about some other modalities. I don't know, Andrew, if you're on, I would call you to come on. Andrew Keel and Muqtadi Al-Nabate, who unfortunately could not join us today, they're setting up this NIH clinic. They're part of my group at the NIH. So I would stop and see if Commander Keel a nurse practitioner in our group, whether he's there, and to present the clinic. Andrew, you just asked me to press next. They're all
You
your
can press.
slides. Just tell me
You can
next.
press. You can press next.
Okay, got it.
So, in my background with the NIH is actually considerably longer than Sean's. I fear is about 25 years. I've started in oncology and with a very heavy background in bone marrow transplant. And then after getting my advanced degree, worked with bone marrow transplant for a period of time before starting with Sean. So there's a lot of parity between in the bone marrow transplant world and the solid organ transplant. So much so that this is what puts the NIH in a very unique spot to have these world-renowned researchers in the immune system in differing in the very types of bone marrow transplant and understanding that to hang on 1 second.
Andrew, anything I could do?
No, my wife was washing the dishes. I'm sorry. It was making noise. Uh, So anyway, so working with Sean, we figured out that there is space to expand the transplant program. And one of the things I've learned is that in the early days of bone marrow transplant, as we learned that the bone marrow transplant patients were living longer, we had to deal with the graft versus host disease of these patients that were suffering that developed from the bone marrow transplant. And one of the first clinics in graft versus host was developed at the NIH to start 25 years ago or 20 years ago. And so this is the same inspiration that we have for the lung transplant rejection clinic. Something must be done now as the science and medicine has progressed to refine the way that lungs are selected, the techniques to have them implanted have become better, the medical management before transplant and post-transplant. So even though the pulmonary transplant, length of progression or rejection is still very short, you're living longer. So there must be a better way to manage. And so that's kind of where we are. And using Sean's work in cell-free DNA and the expertise of the other transplant doctors that we have, we've established this lung rejection clinic. And our goal is very much so to find the early warning signs of rejection using the techniques that are there that we have established, but also finding new ways or new signals to look for. And in that, in finding new signals, we could potentially find new places to treat. And you can go next slide. So in terms of participation, it's very simple. People, adults 18 to 75 with progressive lung disease, you had to have either undergone a lung transplantation or being evaluated for it. So before you even go to transplant, if you are thinking about being listed or nearing being listed and you are well enough to travel to the NIH, then we absolutely would welcome you to come to the clinical center for a variety of for a battery of testing that we have, and it would establish a very good baseline. And after that, after your transplant, we work very well with local transplant centers, both in the surrounding DC area, but also in Chicago, in Florida, and other places in University of Pennsylvania. We have a very good relationship with these programs, and Sean's very well known in the transplant world, so it makes it a lot easier to work together. Next slide. So typically, I don't know in terms of the Lamb Foundation, Dr. Moss has been running the Lamb research arm of the NIH for a considerable length of time. I don't know how many people on this call have participated with Dr. Moss in his studies, but that have traveled to the NIH. So that's where all of our work is done. And so you would continue your routine care at home. Ideally we can try to schedule your visits to coincide with what some of the routine care that you would have at your home transplant center. And we can also do that so there's not duplicate effort in terms of scans or blood work and things like that. And then for follow-up visits, at minimum, we would like to see you every 6 months for up to 3 years. But we could also see you for calls. So if at some point that you are experiencing suspected rejection or you have concerns for that, it would be very fruitful from our standpoint to get an image of what that looks like. It's very rare in the transplant world the urgency is to treat and to prevent, and we don't want to interfere with that. But if we're able to get a snapshot, a view into what rejection looks like on a cellular and molecular level, uh, the amount of benefit that can provide not only for you, but for all of the people that have received lung transplants in the world, it's immeasurable. So there could be potentially more visits than just twice a year for 3 years. Next slide. So the standard hospital procedures are typically what's presented. The blood draw that we have, we would collect cell-free DNA, of course. We would share that with your program, or well, the challenge with that is the standard CLIA certified, or the officially certified lab is the CareDx manufacturer. And I don't know who the other person is, but we can review these results with you. Of course, you've all had lung functioning tests such as PFTs, pulmonary function tests, a 6-minute walk test. Standard for the chest CT scan, we can do we are able to do regular chest CT scans, but our focus is using different modalities that would allow us either a better opportunity to see if they work in the lung transplant world. And one of the things that we're working with the National Heart, Lung, and Blood is a ultra low dose CT scan, with a CT scan with the radiation equivalent to about one chest X-ray, which is considerable considering the standard radiation dose. The other thing, the modality that we're reviewing is what's called a low field MRI. So the standard MRI, if you've ever had one, uses a magnetic field to image tissue. The standard strength of the magnetic field is 1.5. It's the unit of measurement is called a Tesla. The lung MRI uses a 0.5 Tesla MRI. So it is a very, very, very considerably weaker MRI field. But what it does allow us, though, is to actually image the lung itself. The organ is called the tissue in the organ is called the parenchyma, and we're able to image that. And one of the really fascinating parts about the lung MRI is we're able to use oxygen as the contrast agent to look at how well the lung is perfusing. Now, the lung MRI is very much a research-based focus. It isn't something that you would typically find in any hospital in the world right now. It's very much research, but in order to bring things into actual day-to-day clinical practice in hospitals around the world, it needs to start somewhere. And that's kind of what we're doing now. It does allow us to see areas. It could potentially allow us to see areas where there's poor perfusion with oxygen and perhaps damage to the lung, and allow us to map that out if rejection is taking place. Other things that we have would be, of course, your routine bronchoscopies with where we would squirt fluid into your lung, which is called a lavage, a bronchoalveolar lavage. We would test it for cells. We would test it for viruses and funguses and bacteria. And also for cell-free, we can also test that for cell-free DNA as well. Additionally, if you will allow, we would also do bronchoscopy with biopsy, and if we would work, we could work in concert with your home transplant groups if they are willing to work with us, and we can obtain these biopsy as well, not only for clinical purposes but also for research. Some of the areas of interest that we're looking at for the blood draw is we're very interested in what exactly the immune system is doing beyond just what we standard know for lung transplant. There has to be other things that we're not finding or that haven't been seen. And so that's kind of one of the things that we would look at in the blood draw, in addition to the cell-free DNA, taking what's called a deep phenotype, looking at all aspects of your immune system and how they're interacting with not only in your body and how it changes with medication changes, with illness, with differing phases of rejection. The other thing that we're looking at is different pathological techniques, different stains in the pathology slides. We are very interested in looking at a more advanced or in-depth, actually an older type of microscopy, the electron microscope, trying to see exactly how the architecture on this very, very fine, very small level changes in patients with and without lung rejection. These are areas that the rest of the world really isn't looking at, and so only by the challenge is that over 20 years, I think the first lung transplant was in 1978, 1985. I'm somewhere not very long ago. And in that time, you would imagine that if 20 years or 25 years has gone past, that the length of time, the median length of time for the population to progress to rejection wouldn't be 6.5 years. And only over the last 7 or 8 years has the needle moved from 5 years to 6.5 years. And so there must be something beyond the standard that as a whole that transplant medicine is missing. And so in that it's a very fertile area for research, and that is what we're hoping people in this call and other people that that have had lung transplants will be willing to join us in trying to find these very nuanced answers to these questions. And so next slide. And so since this is all research, it's standard that all travel and lodging to and from the NIH would be compensated, would be reimbursed, and you would actually be compensated and paid for the research studies that you undergo. So very rarely do you ever go to the hospital, get an MRI, and then they pay you. And so there for your blood draws and things like that. So it is a switch to the standard. And this is the contact information for me, my email, and it's my work phone. And I'd love
yeah, Andrew will send it to Karen as well.
Yes.
So they have it and they could have a mechanism of distributing it just in case for those who are not here. Andrew, thank you very much. I will try to move through. I have like 5 or 6 more slides that I'll move through because I would like to leave about 15 minutes, Andrew, so that we could have about 10. I will finish in about 5 minutes so we could have some type of a discussion. Andrew, thank you for that overview. I'll leave the information here for just a little bit longer, but we'll share this with you for the rest of the group as well. Now, why do we want to create this clinic? Andrew has hit a lot of the points, so I would go through these slides really well. Are all rejection created equal? When a patient has rejection, we treat them the same. We give our patients the same immunosuppression. Are they all the same? You can look at this kid here trying to figure out which shoe he would wear. I don't think he knows that, or she knows that this shoe is likely bigger than his leg, but he's going to try it anyway. That's the way we think about the way we currently treat. We treat all our patients the same. If I show you these two here, if I did not put the title, it's going to be hard to tell which one is a jaguar and which one is a leopard. They look the same. We diagnose rejection and we diagnose things based on the way they look. They may look the same, but are they created equal? They may be different. We hypothesize that this is the bane of how our studies are now. They figure this in lung transplant, in lung cancer, where if you have a lung cancer, they're not all the same. They can go in the deep molecular phenotype to figure out what type of cancer you have. So are all rejection created equal? We want to answer that question at the NIH, collaborating with you and your providers. If you think about antibody-mediated rejection, it gives you a good example of why we are concerned. Here is our cohort at the NIH. We started with about 400 patients. About half of them develop antibodies to that donor lung. We call it DSA, or donor-specific antibodies. But not all of them go to get AMR. We don't know the difference between the antibodies that cause rejection, antibody-mediated or not. 50% get the rejection, half of them will get antibody-mediated rejection. Then look at the antibody-mediated rejection here. We treat all the patients the same. Only about 1/4 to 1/3 of them respond to that therapy. somewhere between 2/3 and 3/4 of them don't. They go on to develop chronic rejection. Unfortunately, are these diseases created equal? We want to hypothesize that they are not. If you remember the funny story of the Titanic, where you see a big iceberg, you don't know what is underneath. That's where we think about rejection. Rejection is what we see up here. We don't know what is underneath the surface. Are there trouble with the blood vessels? What's the innate immune doing? Andrew talked a little bit about that. What's the adaptive immune? How are antibodies progressing? What's inflammation? What's the molecular pathways? We need to assemble these information. We think all this is not the same if you go from one patient to the next. So it's not enough, we believe, to just say rejection. We believe you need to pin down the molecular fingerprint of that rejection, because the molecular fingerprint is what the drugs should be treating. So we're setting up this clinic in not only to detect early signs of rejection, we want to develop these underneath, these things that are underneath that's driving rejection, the molecular pathways. And if we can do that, then we can identify better drugs, better therapies for rejection. I have to insist that the goal now is research. There's likely not going to be a direct benefit to any patient that come to participate. But I hope, just like the blood test, we started with patients who volunteered. But guess what? We have a blood test now that 70% of US hospitals use. So those patients, I hope, who volunteered, I'm hoping they will say, you know what? I contributed in making this. And we're hoping that we can do the same to find therapies for rejection. I want to stop here for a minute. I have Commander Keel's contact information here. And he and I would be available for questions. But before we do that, please allow me to start by thanking the patients who volunteered for Graft 1.0. If you remember, in Graft 1.0, our goal was to find a diagnostic test for rejection. And we did. We found a test now that we could use to monitor our patients for rejection. And we could not have done that without these patients. We also like to thank our colleague from the Genomic Research Alliance for Transplantation, all the hospitals who volunteered to participate in this consortium. This here below are the different funders, different grant institutions, plus NIH that's funding our research. But more importantly as well, allow me to stop by talking about the people that you see on this map. I have to say, this is not the most updated map. One of our postback, Isabella, was updating this and did not send it to me in time. Hopefully, if I get it on time, I'll show that, because we'd like to truly appreciate the people underneath that's doing this work. Not only do they think differently, the diversity of the group is truly remarkable. The way they think, the way they work, and working together then, we've seen that bringing this diverse group of people into one roof, bringing all their thoughts and bringing them together, the productivity can be really high, ultimately to improve the life for our patients. And we're extremely fortunate to be working with them to improve their life. And I'll stop here. I'll stop sharing to take any questions. Thank you.
Yes. Thank you, Dr. Sean, for this very informative presentation. We are going to go ahead and open the chat box as you suggested, and we would love to take any questions that are out there right now. You're getting lots of applause, I'll give you that. Any questions, thoughts, concerns?
Cindy, it's Hallie speaking. Can you hear me?
Yes. Yes.
Unfortunately, I can't get into the chat box. This has been absolutely phenomenal. I'm quite blown away by all of this. Is it possible for us to coordinate this visit with the LAM protocol so that things like the CTs can be shared, potentially blood can be shared so that we're not double dipping on everything?
I actually ran into one of Dr. Moss's NPs. Can't remember her name. I used to work with some of his research team, so as well. Yes, that would be for patients that have had a lung transplant that are involved in Dr. Moss's LAM studies. It bookends very well to have all of the. In fact, a lot of the imaging, the low dose CT scan, the low field MRI. These are things that are offered that are sought after in Dr. Moss's study as well. So there actually is a lot of overlap between the two. So yes, we can absolutely coordinate those two.
Wonderful. Thank you. I really appreciate that.
Dr. Sean, we have quite a few patients here tonight that are not post-transplant. So we've got patients from all different stages of their disease. Are there studies right now that they can participate in as pre-transplant patient? Is there information that you can gather from them at all?
So, as Andrew showed here, we are recruiting patients who have advanced disease that their doctors are considering transplant. And in addition, we're recruiting patients post-transplant. Indeed, we would really like to get these patients when their disease is advanced, but before transplant, because we believe that if we map their immunity, we map the host, then when that donor organ comes, it may be easier to study how the host and the donor are interacting. So the most ideal case for us would be take a patient that is on the transplant list, recruit them to the NIH, get baseline, and then follow the patient after transplant. However, if you have post-transplant patients as well, they can join the study. We usually would coordinate with the hospitals to get as much baseline information data as we have. Because most patients before transplant, guess what? They got a CT scan, they got some blood, they have all these different things. And then, so if you look at that, then we would be able to get some baseline information even for patients after transplant. So to answer your question, answer is yes.
Yes.
They
Okay.
contact Andrew or contact us, and then we would review them and discuss this a little bit more with them. But we'll be very excited to have that discussion.
Great. All right.
How
Other
about
questions?
that? I want to ask something. I am far away from the USA. How can we found like this and make this test to? Because I am in the list for transplant, and I am from Cyprus. I am make the honors to Athens the transplant. This they are make there. How can I find like this?
So
The test that
yeah. So there's very good news. Cyprus. Can you? My geography is terrible. Is it New Italy or Greece?
it's Cyprus near the Greece.
Okay. So I have some colleagues in Bologna in Italy whom have started the test, and it's also now in Greece. So because a lot of European countries 3 years ago they picked up the test, but they're still developing it. But the people from Italy and one group in Greece, they've started using it on their patients. So I suspect that if you give us some information about your transplant center, Fiorella Calabrese is the professor.
Onatio Transplant Center.
Okay, Andrew, do you want to just write it down? We're going to try to, and we could put your, Andrew's email is there. If you want to send an email, we can find your transplant doctors and make sure either they have the test already. Maybe you don't know that. Maybe they do already. But if they don't, then we can connect them to the right people that could make sure that they get that test. We think about it from the NIH. We don't make money out of this. I want to make sure we're clear. But however, our joy is really because we believe the test helps patients. So the more patients we could help, then it feels like we're really reaching our mission, because our mission is to bring that test to patients. So send an email, we'll connect you, and then we go from there. And good luck
Okay,
with good luck with this journey.
thank you.
So we have a couple more questions. I'm just going to do this out loud because I know not everybody is able to see the chat box. So how many days is the testing, and how long would the stay at NIH be? Andrew, you want to go ahead and answer that? I know you wrote
Yes.
it out, but you want to give us some more information on that?
So the plan is the initial idea is to be able to do our study visits in typically 2 to 4 days of treatment. It's a pretty jam-packed schedule if we try to do it all in one day, especially for people that are flying from outside of the local area, that come from the local area. So usually 2 to 4 days is about that. Allows for any scheduling nuances and things of that sort. There's always the caveat that, if we find something acute, we can't ignore it. And depending on its level of acuity, it's either it would be a very, we'll say urgent, we'll say timely referral back to your treatment center. We would be in contact. We would be in contact with them, or if need be, we could initiate a therapy at the NIH if that is necessary. It isn't our intent to usurp the care provided by your regional or your primary. Your primary transplant team will remain your primary transplant team. We very much think of us as more of the learned consult uncles of your transplant. In terms of Ms. Harmon's question about the lower dose of steroids that detected as earlier.
Let's read
Dr.
that
Egg,
question first before you answer
yes,
it.
go ahead. Okay.
Is the lower dose of steroids if detection is earlier? For example, I did high dose infusions after suspected rejection, but you mentioned only upping the dose by 5 milligrams. I'm just wondering how that works.
Okay, Andrew, let me take that. So
Yeah, go ahead.
I want to say in these patients, we increased the dose by 5 milligrams, and that worked because we have in the lab, we have this young lady, Wu Jin. You give her a sample, within the day or two, you get an additional cell-free DNA results back. So because we have that capability, we can track how your cell-free DNA is changing. If we increase by just 5 milligrams, if it's working, we would know in about 2-3 days because your cell-free DNA would drop. If it doesn't drop, if it doesn't drop, then you titrate the dose. In the patient I showed you, 5 milligrams was enough. But I hope another take-home message that I'm potentially leaving you is that we also believe not all rejection are created equal. So another person, you give them 5 milligrams, it may not work. They may need a higher dose of steroids, or they may not need steroid at all. They may need a very different medication. So you really have to tailor this to the patient. It's the one size shoe fit all doesn't work. You gotta tailor it to the patient. So hopefully I've answered your question.
Thank you. So one thing to keep in mind with LAM patients is our survival rate post-transplant can be quite high. We
Yes.
have post-transplant LAM patients that are going on 20 plus years. It's something we're very happy
And
about and proud of. And
that
so we've got some questions here, right? So if someone who is now post-transplant, they participated in Dr. Moss's protocol, but it's been a while. Do you have a maximum time differential that you're looking at here? Does it matter?
Andrew?
in fact, there is a wealth of data that the long-term survivors of lung transplant have that is frankly untapped. What is it that makes the long, because there aren't many. The very fact that the LAM patient's time to rejection is 12 years is double what the standard population is in and of its own self. Because we're all humans and we all have the same physiology, as much as we're all different. Something is different. And so the LAM population in and of themselves has answers somewhere in your immune system, in your molecular makeup that should be explored. We have a patient that isn't a LAM patient. He's a gentleman. He is 22 years post lung transplant. He was transplanted at age 7. He's 36 years old, who has an underlying immune deficiency disease, but his lung function is probably equal to mine. And he's just on a whisper of one small dose of immune suppression, and it boggles the mind as to why he is able to live that long with normal lung function. So the long survivors have their own unique, and we absolutely are turning our eye to them.
Wonderful. And how many patients are you hoping to enroll in this study?
100 initially.
100 initially. Great.
And let me add something to what Andrew says. Another thing we are also cognizant is that we want to learn what is it about your colleagues or the people here. Why is it that they live so long? They may teach us. We want to learn that. You know how sometimes as researchers, we go on our tangents trying to make the biggest discovery, but maybe that bigger discovery is right in front of our eyes right now. Can you just tell us what's going on? And if we get your blood samples, we collaborate with Dr. Moss. He has the history of your samples over time. What can we learn from there that would tell us about how well you are doing now? And can we then take that and translate that into other patients? So I think not only are we really going to be enthusiastic to enroll patients from this group, but I also want to implore you that what you're going through may teach us something that may help other patients that don't live as long as this. Patients with pulmonary hypertension, for example, their median survival is about 3 to 4 years. LAM is 12 years and it keeps going. There's something that's happening with LAM. Can we learn that and help these other patients? So I think your participation would be really key. The second thing that we've struggled with in transplant is that it's hard to find patients generally in our cohort who've done so well just because we started the research just 5-6 years ago. So any patients that we've enrolled have just been 5-6 years. Now you coming to participate, you've lived 5, 10, 15, 20 years. Man, you're just giving us, open a new door that we've not even seen before. So I think there's a lot of opportunities that we can learn from if we get participation from this group.
Wonderful. Ladies, I think this is an amazing opportunity for us in an area that certainly has been untapped. So we have, I'm post-transplant December 2025. I'm receiving the cfDNA testing at CHI Baylor and St. Luke's Hospital. Would you still want me as a test patient? And Andrew has answered that yes. So any other thoughts or comments on that?
No, there is no the length of time. The caveat for if you had a transplant 3 weeks ago, we would prefer that you stay in your area for the transplant at least until 3 months. We want you to be stable enough to fly where it's not. So 3 months is the minimum that we would want to see you. And most transplant centers wouldn't be very.
No.
It wouldn't be very amenable to you traveling that far away. It's such a
early on,
sensitive early time. So no, but after that, yes, we would absolutely. In terms of that, so if you want to go to the next questions.
Yeah.
Great. Yeah. So yeah, go ahead, please.
Let me add something to the patient, to our colleague. It's not a patient, the person that asked that question from Baylor. Indeed, I was in Toronto just last week. The chief of transplants from your hospital, I know him pretty well. We had coffee together. So if you were to tell him that you were coming to the NIH, I told him he should know I told him about the study already. So he would know. But I think once you're out of your transplant and you're stable, this is a partnership. We're not taking patients from their primary. Indeed, we want to integrate such that when we get all these, we have cool toys at the NIH, new equipment that is just nowhere else. When we get these results, we don't want to just pass it on to you. We want to tell your doctor as well. So maybe that information can help them and help you so that your care can be better. So in our mind, it's a partnership, three-way partnership between you, your primary team at your local center, and us. So we have to really interwoven and make that really interwoven. I will stop here. I know your doctors quite well, and hopefully
Okay.
they would be eager to collaborate with us.
Kathy, did you want to say something?
Did you meet with Dr. Lore? Who did you meet
No,
with?
I didn't. Not Dr. Moore. The chief
Lore.
is sorry.
Loire or something like that.
No, I'll check his name now and I'll tell you in a minute.
No problem.
Yeah.
Thanks.
And then how good is the cfDNA when one is post-transplant more than 10 years?
As I just told you, all our patients, the maximum that they are now is about 5 years, 6 years. 10 years, we don't know.
Okay.
We figure it out. I think it almost becomes a new area of research. You say, oh, these people who are doing so well, what is their cell-free DNA? We don't know that because we've not studied it. So it really gives us a new area where we could say, okay, for people who live in long, this is what normal looks like for long-term survival.
Great. And then you said you're wanting to enroll 100 patients. Are those only rare lung disease patients? What spectrum are you looking at for this?
The spectrum is, I want to be very, very clear about this one. The spectrum is patients that have had lung transplants. That's an absolute,
period.
Of course. They're the period, that's it. And be clear, only those that are actively considering and being evaluated for lung transplant. If you have a rare disease that you know ultimately will end up in transplant, or there's a high likelihood, that I understand, and that is a hard spot to sit in. But fortunately, on the flip side, you're not being considered for transplant yet, so which means you're still quite well. So we would need you to be at that tipping point of being evaluated for transplant before you would be eligible for participation in this study.
Got it. Great. Thank you. Another question for your graft 1.0 patients. Have any had a second organ transplant?
Oh, that's actually, I showed you some data. We have quite a few people who've had, well, let me make sure I answer the question. Second organ transplant, as they've had a lung transplant plus a kidney transplant, or a lung transplant plus a heart transplant, that's a second organ, or they've had a lung transplant and that organ got rejected and they got retransplanted. I don't think I understand the question. So they're two separate organs, second organ transplant, and we've had both.
I would say what I was asking really was about, you've had a lung transplant and then you needed a kidney transplant.
Oh, yes.
Because it is from what I've heard, there's a certain percentage of lung transplant patients who ultimately need a kidney transplant. And so I'm just trying to figure out if you've tapped into that market.
Yes. So we do.
Sorry.
We don't have a big proportion of them, but I think I talked to you a little bit about this senior scientist in our group, just a brilliant guy. For a long time, we're just stuck. We said, we can't study these guys. They have two organs. What are we going to do? But Moon came up with another test that he can not only say cell-free DNA, he can tease out the cell-free DNA coming from those different organs. Indeed, there's a cell-free DNA test that I did not show because of time. With a vial of blood, what if I can take a vial of blood? What if I can not only tell you about your transplanted organ? As our patients, sometimes they get liver trouble too. Sometimes they get kidney. Sometimes they get heart. Sometimes they get brain trouble. Or they have nerves where they have shakiness and all that stuff. What if we can tell you all that? So that test is not ready for clinical use yet, but that's another test that Moon developed, which we're trying to speed that up into the clinic, such that our hope is that coming to the NIH, we don't just tell you about your organ, your transplanted organ, but we can almost give you a snapshot Think about a molecular scan. How you get a CT scan from head to toe. What if we can provide a molecular scan to you, where we look at all your other organs and almost give you some type of a report card? So that is the test that is been developed. Is research grade now. Over the next year or two, we're going to work for that test to become clinical grade. And that's another thing that will hopefully, if I'm lucky to be invited again, I'll tell you about that these new test modalities that are coming up. So back to your question, answer is yes.
Great. All right. Any other questions out there? Hey, Dr. Sean, is there any final thoughts you want to leave us with on this topic, or Andrew
Yes.
as well? Mm-hmm.
Andrew, go first, please.
I am I am honored to work with all of you in terms of this this area of research. It is it's I've been doing this for quite some time, and it's good to find an area that is so rich in possibility, both with the current technology that we have in the lab, with this cadre of very dedicated and stable scientists that Dr. Edgar has in his lab. It's remarkable to be there. There's being working at the NIH and having the ability to have a lot of research crosstalk with other subspecialties. It's a little bit different. This is not to throw shade at Baylor or Mayo or St. Joseph's or anywhere else, but it is unusual to be able to walk literally down the hallway or one floor down and speak to someone that has an entirely different view, has an understanding of transplant medicine, but an entirely different view of seeing it. If you are in the Baylor Transplant Clinic, all of those transplant pulmonologists, for all intents and purposes, view transplant in somewhat of a similar prism. So when you have people that view it differently, so being able to to have other people give their point of view opens our eyes to a different way to consider a transplant. And this is, I think good things can come from this.
Wonderful. Yes.
I would not add very much. I would say we here represent Andrew, myself, and several of my lab members that are here, all from the students like Nathan, Hesik, all of the people that are participating. We've been fortunate to find a team at the NIH that we all can come from very different backgrounds, very different people, but we're all pointing to the same mountain. The first mountain we wanted to point to was to find a blood test that can tell you something is wrong with the lung. And in a very short time, this team effort had been successful. However, we think that the next team effort is to find better ways of giving immunosuppression and for treating rejection. We've realized that the way to build that team, we can have the smart people at the NIH or all kind of this. It's not going to work. It will not work. You need a third partner in that equation. That third partner is the patient. We cannot be more excited if we entice you enough to call Andrew to participate. And I would insist that we're not saying you have a direct benefit on day one. No, nobody's saying that. But I hope is that by learning from you, by learning some of the things, one day, just one day, we can change survival for all lung transplant patients. The 5 years, 6 years survival, I gotta tell you guys, it hits me the wrong way. It's just not acceptable. Can we change that? I think if we can partner together, we can. I cannot thank you enough for inviting us to participate here, Andrew and I. And we're representing a big group, but thank you for this opportunity. We hope, truly hope, that you could partner with us in this next journey. Hopefully, in a few years, we can begin to see the fruits of that. Thank you, and I'll stop here.
Thank you. Thank you both for being here and for this incredible the work you're doing, the information. Lamb patients are a very motivated group of folks. I can only imagine that you will have quite a few of them reach out to you from this. And I'm excited about this and excited about the future and what it might hold with your research. So thank you. This is just remarkable. You're getting lots of applause out there. And I even had somebody who texted me and said that Dr. Sean is a fantastic science communicator, and I would love to see him in more lamb calls. So we hope to continue this discussion as things progress.
Yeah.
So thank you.
Yeah, thank
All
you
right.
very much. Well, thank you very much.
Thank you.
Dr.
Thank you for
Sean.
being here. Yes. So we just have a few more things to tie up before we end this evening. I want to remind you of the importance of donating lamb tissue for research. The most common type of tissue that are typically used by our researchers are lung, kidney, and uterine tissues. So if you have an upcoming procedure, or maybe you recently had a procedure and you would like to donate, please consider giving your consent for that donation with the NDRI. And if you have any questions on that, you can contact our Circle of Hope Transplant Support Program Coordinator, Karen Kinsey, at kkinsey@thelambfoundation.org. And to dovetail on what we just heard, of course, if you are considering transplant, I don't know about you guys, but that was one of the things that really excited me, is that if you are in the process of getting on that transplant list and also post-transplant, that they want to have you participate. I think that's remarkable. And so if you are considering transplant, you're actively pursuing one, or you're post-transplant, please consider joining our Circle of Hope Transplant Support Program. This would be another great place for you to connect and also for people to share their experience, even with this particular program. You can find more information on our website under Find Support and Circle of Hope. And then finally, our next symposium in your living room will be on Tuesday, June 2nd, where we are fortunate to have Dr. Nishant Gupta presenting his LAM 101 Key Concepts and Common Challenges. This is what he presented at Lamposium this past fall. And remember that June is Worldwide Lamb Awareness Month. So be sure to follow us on social media for special highlights prior to and during this important month. So thank you all for joining us this evening. It's always a pleasure to be with you. And we look forward to seeing you at our next webinar. Have a lovely evening.